The title is Anesthesia in Pediatric Radiation Oncology. Dr. Gennaro, please start.
Thank you. First of all, I want to say thank you to organizers for having accepted me to talk to this wonderful, in this wonderful meeting. And I come very far from here. I come from Italy, from Salerno, that is a joyful city in near the Mediterranean Sea, as you can see. And it's near, maybe, you know, Capri or Positano or Amalfi, the famous touristic places. Salerno is also famous for its heritage, its Greek heritage with the Paestum temples. And it's famous because it was the first medical school in European world in the 8th or 9th century. One every 600 children before 14 years old is diagnosed with a tumor. And tumors are the most important cause of death after car crashes at this age. Every year in Italy, there are 1,600 cases, and almost 200 in Naples metropolitan area. That's called Regione Campania. That's where lives 6.5 million inhabitants. As you can see, this is Naples metropolitan area. On the right, you can see Naples. On the left, you can see Salerno. That's my city. And there is a big hole at the center of the lights, a very big hole. What is this? This is the point in common we have with Tokyo and Yokohama. We are very far, but we have one point in common. You have wonderful Fujiyama, we have Mount Vesuvius, and are two volcanoes. We live under volcanoes. And so, in this area, there were no children was treated with radiotherapy in anesthesia until 2009. Pediatric tumors are largely treatable, curable, radiosensitive, with 80% of patients who are NED at 3 years, 75 at 5 years. So we can cure these patients. These results are mainly given by a multidisciplinary approach and wide use of aggressive treatments. 50% of these patients need radiation therapy. We work in Salerno, 100 kilometers far from 2 pediatric hospitals who stay in Naples, who are Santobono Hospital and Pausilipon Hospital. So we use, we make a wide use of telemedicine. Radiation oncology is generally used for a curative intent, more than palliative one, in our experience. When we started in 2009, no child was treated, as I said, in our region in concomitant anesthesia. Children went to other cities, mainly in the north of Italy. So in 2009, the sun was beginning to rise over Vesuvius and over the Bay of Naples. We receive young patients in a warm and quiet climate, in a positive working atmosphere. We joke very much with them to gain their trust and give them serenity, removing every anxiety as it is possible. This procedure surely is very time-consuming at the start of radiation therapy, but not time-wasting, because if you gain a child trust, it is for the whole treatment course. So you can move faster on further steps. These are two my technicians who play with the child. And this is our bunker. The expertise of the team in the psychological approach is very important to remove fear and anxiety, because we make the procedure of anesthesiology in pediatric radiation therapy only when it is really necessary. Radiation oncology has a great advantage over other medicine disciplines. We don't give pain, but children often come to radiation therapy departments really shocked by chemotherapy or surgery. Chemo sometimes is very disturbing in our experience. We were obliged to give anesthesia to an 8 years, 6 months old boy. So these are some pictures of our work. We organize also fests with the very young patients and their parents. Our cases, we treated the 99 patients. 67 were solid neoplasms and 32 were lymphomas. 29 brain tumors, 12 neuroblastoma, 11 Wilms tumor, 10 sarcomas, 2 Ewings, and 3 other tumors, 22 Hodgkin, and 10 leukemia. Brain tumors were 29, 8 medulloblastoma, 8 glioblastoma, 3 brainstem glioma, 4 pilocytic astrocytoma, 1 pilomyxoid astrocytoma, very aggressive subtype, 3 ependymoma, 1 germinoma, and 1 meningeal melanoma. 5 patients received stereotaxis radiation therapy. We don't have like in Japan, a great technology, because we have a Baylab, Macro Multilith, and Electralinac. So we used to make stereotaxis not with gamma knife or cyber knife, but with our Linac. We made 5 patients with stereotaxis treatment, always as a boost in a continual course with 3D radiation therapy. 2 were medulloblastoma, 1 was pilomyxoid astrocytoma, and 2 ependymoma. And these are our cases. This is a pilocytic astrocytoma grade 2. She didn't need anesthesia because she was 14 years old. This was a 6 years old female. On 2012 surgery, ependymoma grade 2, residual neoplasm. She made 4 cycles of chemo, and then 3D radiation therapy with a boost of 2 fractions of stereotactic radiation therapy, 4 grades for every fraction, till a dose of 67.4 grades. We consider the dose at the 80% isodose. We don't use we use a mask for immobilization, a Baylab mask. This is a female, 3 years and 11 months. She received 35 anesthesias. On February 2014, had surgery for ependymoma grade 3 with a residual. Made 2 cycles of chemotherapy, then had a second surgery. We made 3D radiation therapy, and then a boost of 2 fractions of 4 grays. So we made 67.4 grays. This is a 7-year-old with a medulloblastoma in metastatic phase stage, grade 4, stage 4, metastatic phase with metastatic stage with metastasis at the angle, at the pontocerebral angle, left pontocerebral angle, as you can see. He made a very aggressive treatment schema with also a mega chemotherapy and bone marrow transplantation. Then he received a bis in D radiation therapy two fractions separated 6 hours, at least 6 hours, one from the other. He didn't receive anesthesia, but he was treated also with stereotactic radiation therapy boost. We gave 1.5 grays BCD and received a total dose of 68.7 grays. So we reach very high dose because we think that radiation therapy, chemotherapy, surgery makes a real battle against cancer. And in pediatric cancer, you may also have a toxic effect because we can cure, but we must give a very aggressive treatment, and we must be really careful to not give a later effect. So it's really a fight. This is an ancient mosaic of the Pompeii, a city ruined by Vesuvius in 79 before Christ, and you can see Alexander the Great who fights against Dario, Persian emperor. So this is our cases in anesthesiologic patients. There were 14 patients for 236 fractions. As you can see, in 2009 we made only 5 patients because we started our work. One patient had anesthesia. In 2010, 3 patients had anesthesia over 5. In 11, 2 patients over 8, and in 14, 1 patient over 23. Mean age was 4 years and 7 months. 1 patient was 13 years old, 1 patient 8 years old, but these were special cases. 18 years old boy was shocked by chemotherapy, as I said before, and now I shall talk about the other old one. Other 12 patients aged from 2 to 6 years with a mean age of 3 years and a half. 1 patient over 99 abandoned the radiation oncology course for tumor progression during radiation therapy. After only 4 fractions, he was 13 years 9 months old and suffered fast-growing spine mets from leptomeningeal melanoma with meningosis syndrome. A very large CTP for such a radio-resistant neoplasm, a desperate situation for him, for us, because as you can see, the airman is, you can see there is a lot of leptomeningeal metastasis at the spine. So, when children, let's talk now about anesthesia. I'm a radiotherapist, not an anesthesiologist. When children are very young, in special situation, we need anesthesiologist consult. They use sevofluran, USP, and a gas, an allogeneic drug, allocated to a laryngeal mask, and a delivery system. Premedication, like midazolam, is made only if children have a central venous catheter. We use a laryngeal mask for everyday treatment. Sevofluran is usually irrogated at a 6% concentration with oxygen air mixture 50% and gives anesthesia in 2-3 minutes. Then we reduce the concentration to 2% for maintenance. It's pleasant to inhale, rapid in induction, very reliable at this concentration. We monitor from outside the radiation book the vital signs of patients and observe them by a rotational dome camera. As you can see, After radiation session, we stop the severing. Awake is fast, 15-20 minutes from removing laryngeal mask, and usually children are in very good status in 45-60 minutes. We had one problem with a child because that was provoked by the crying. Awake usually begins with the crying episode. The crying is provoked once an apnea in a large Pons tumor. So we decided to suspend the anesthesiological procedure and tried a more accurate psychological approach with success. In our experience, several is very reliable. We had no shattering episodes. The procedure is very safe for prolonged radiation courses. From 2009 to 2012, in 4 years, we made 9 anesthesias, nine patients, over 35 patients, so 25%. From 2013 to 2015, 2.5 years, over 64 patients, we made only 4 patients with anesthesias, 6%, because there was more, we became more expert in a psychological approach, and we use wider the table to reduce children anxiety starting from April 2013. Wide use of tablet. Tablet sedation for us, radiation therapists, is very important. We discovered this thing starting from April 2 years ago. And we are with adult and child are very attracted from TB. The TB attraction seems to come from our biological orienting response, first described by Ivan Pavlov in 1927. The orienting response is our instinctive visual or auditory reaction to any sudden or novel stimulus. It includes dilations of blood vessels of the brain, while constriction of blood vessels to major muscle groups. It's a part of our evolutionary heritage, a built-in sensitivity to movements and potential predatory threats. Alpha waves are blocked for a few seconds before returning to their baseline level, which is determined by the general level of mental arousal. The brain focuses its attention on gathering more information while the rest of the body quiets. This is valid for adults and for children, and especially for children. So this is the first boy. We used the tablet, and as you can see, this is not aesthetically very good, but it's the first case. And this is a 3 years, 4-month child with a Wilms tumor. We made 10 fractions with this system. Incredible, but it worked well. So now we use it widely, and we have constructed an homemade support that is more efficient, maybe. As you can see, this is his daily use. This is in a 7-year-old boy with LLA. Now the sun is beginning to rise over Vesuvio and Beit. Want to say arigato to the audience. These are our colleagues that work together from Naples and Salerno in this work. And I want to say, this is my equipe, they want to say thank you in a serious way, but also in a joking way. Thank you very much.
For your very interesting presentations. Tablet is very interesting. now the topic is now open for discussion. Is there any questions or comments?
Thank you. Thank you for your very impressive presentation. I completely agree with you, especially for P cases. Such a small arrangement is very important to improve the condition to receive the chemotherapy, surgery, and radiotherapy also. So I have two questions. At first, very local questions. You applied to the ISRS to the pilocytic chiasmatic astrocytoma, the first cases? Pilocytic, mixed soil, I don't remember well. Okay, so how did you make the clinical target volume to this patient? What's the target? T2 high intensity view or gadolinium enhancement view? How you can make a lane area? How could you decide the area of the target? It is very, I think, at the side of the neurosurgery, it is very important point. Please let me know.
Yes, I made an MRI, a fusion with CT, and MRI with gadolinium, naturally, and I gave 5 millimeter expansion from CTB to PTB, and then I calculate the dose to the 80% isodose, invasing all the target.
But usually very hard to distinguish the normal chiasm, optic chiasm in the structure.
Yes, but as you can see, as you have seen, it was a large residual mass after surgery, so you can't spare completely the optic ways of the patient. Anyway, we made the treatment 6 years ago, and the girl is well alive.
Okay. And how was going on this patient after the?
What?
How was going on after these procedures? The tumor control is good.
Very well.
Very impressive.
With no problem at all.
Oh, great. Oh, and
she's alive, and no problem. The mass stays there now, but is blocked. I hope, because there are a lot of years.
Oh, great! I have also.
It's a very aggressive histologic tumor, because it's very rare and very aggressive. And so we gave also a high dose, because pilomyxoid is very, very aggressive.
Oh, great, thanks. Our last question is, usually in your country, who follow up these patients? Neurosurgeon or radiologist? Neurosurgeon.
Yes.
What do you think about it? I'm neurosurgeon. Is it a good choice?
This is neurosurgery and neuroradiologist work with neurosurgery. They usually see a lot of radiation toxicities. They talk about radiation necrosis. I think with a lot of in an easy way, they talk about radiation necrosis, and also in patients who are fairly well. And so we think that the follow-up must be done in a multidisciplinary approach by the neurosurgeon, the neuroradiologist, but also by the radiotherapist, because we are the protagonist of this work. So this is a really good question, and in my country is the neurosurgeon and the neuroradiologist. But I think that this is not a good thing, because it's also very dangerous for us radiation oncologists.
Thank you very much. Thank you.
Is there other questions? can I ask one question? How many medical staffs are there in pediatric radiation therapy or pediatric anesthesia?
Yes, when we make anesthesia, there are 2 anesthesiologists. One anesthesiologist, always there are 3 nurses. I have in my service, in the radiation oncology department, 3 nurses who have worked for a lot of years in anesthesiology. So I am lucky in this because they have worked for a lot of time with anesthesiologists. They know more than me the laryngeal mask, the number of laryngeal masks, and so on. Anyway, when we make an anesthesia, there are a lot of persons. I think at least 7, 8 persons nearby.
Thank you.
Like in the slides of the colleague before, the procedure is exactly the same. Thank you very much.
Is there any other? Okay, we